My name is Marquette Rose. I'm one of the reproductive psychiatrists here at the University of New Mexico. Today, I have the privilege of introducing someone who I've admired for many years for her significant contribution to the field of reproductive psychiatry, Dr. Marlene Freeman. Dr. Marlene Freeman is a professor of psychiatry at Harvard Medical School. She is the associate director of the Center for Women's Mental Health at Massachusetts General Hospital and the Abra Prentice Foundation Chair in Women's Mental Health at MGH. She is the medical director of the Clinical Trials Network and Institute at MGH. She completed medical school at Northwestern University Medical School, residency at the Harvard Longwood Psychiatry Residency Program, and a research fellowship in the Biological Psychiatry Program at the University of Cincinnati College of Medicine. She previously directed women's mental health programs at the University of Arizona College of Medicine and UT-Southwestern Medical Center at Dallas. She is the editor-in-chief for the Journal of Clinical Psychiatry. She is on the board of directors of the American Society for Clinical Psychopharmacology and is also a fellow of the ASCP. She is a fellow of the American College of Neuropsychopharmacology. So with that, Dr. Freeman, the floor is yours. Thank you so much.
Thank you for the very kind introduction and for having me give grand rounds. I really appreciate it. I really appreciate everyone tuning in on a Friday afternoon also. It's I will do my best to make it worth it. So we're going to be talking about postpartum mood and anxiety disorders. I have my disclosure. And before I start, I just want to invite all of you to join us if you're interested at the MGH Center for Women's Mental Health virtual rounds. So one of the things that I'm really privileged to have at Mass General in our Center for Women's Mental Health is a group of perinatal psychiatrists where we round every week. So we basically have peer and group supervision. And, we treat patients that are often very ill and a vulnerable population. So ever since coming to Mass General, it's been something that I truly value because other places I've been, I have not had that experience where I've had so much peer support. And so when the pandemic started in March 2020, we had colleagues, and we went virtual in our groups rounds. We had colleagues from across the country ask, well, can I join you? Because I know you're rounding virtually. And so what we did, Lee Cohen and I started virtual rounds at the Center for Women's Mental Health, just so separate rounds from our groups, and basically opened it up to any healthcare provider with interest in perinatal mental health. So multidisciplinary, no cost, you just have to register and log in. We've had some people join us every single week. Sometimes people just drop in. We have very seasoned perinatal psychiatrists, we have therapists, we have doulas and midwives, and we have trainees of all different disciplines. We have a lot of nurse practitioners join us. So I would just like to mention this, that if you're interested, please see our website. It's www.womensmentalhealth.org under the educational tab. And we would love to have you. And so it's mostly case-based learning where we talk about like whatever and whatever hot topics are around in the area. So we're going to be talking today about postpartum mood and anxiety disorders. And just to kind of start and frame this, so postpartum blues is actually not a postpartum disorder, but is actually really within the range of normal. So most women will experience some mood symptoms in the postpartum, about 70 or 80%, that are transient, mild, don't interfere with functioning. So women might feel like sad or quote unquote hormonal, but the sadness is like if you see like a sad movie or a very touching Hallmark card commercial. Like it's very superficial. It's not like the real deal, like a major depressive episode. But the reason I mention it is it leads to a lot of confusion. So many women with major depressive episodes in the postpartum are told, oh, that's normal. And so it sometimes needs some differentiation. What is postpartum blues? What's the beginning of a major depressive episode? And it's hard to tell sometimes what's normal or not, but functioning and persistence is often are often key variables. So postpartum depression, I have to say one of the biggest surprises of my career is how much debate there has been over what the definition of postpartum depression is. So roughly, postpartum depression is a major depressive episode that occurs in the postpartum. DSM-5 now has a peripartum onset specifier, so it onset in late pregnancy or within 4 months of delivery. And there is a lot of controversy about this because from a biological standpoint, there really isn't like a lot of clear biological evidence for one thing that's postpartum depression. So the DSM-5 committee really came up with a definition of onset within 1 month postpartum. But the advocacy in patient communities and I would say perinatal mental health care providers often would state that we really should use a much broader definition. Because if you ask patients what they really, and I've heard just this debated as a surprise in national meetings, to my surprise initially, patients really don't care what we call it in DSM-5, but they really want us to understand the context in which they're suffering. So a postpartum parent who has a new baby at home, she may not be sleeping, has so many variables, really wants to be understood in the context with which she's presenting. And I say she and use the word like mother, maternal, but I want to be inclusive, and we treat all individuals who would identify with this with respect and individuality, but I'm going to default to talking about like she and mothers, just to let people know that. But patients really want us to understand the context. So a lot of times people argue really for a postpartum definition being 6 months out, 1 year out postpartum. And so there is a lot of heterogeneity, which we'll talk about. We'll also talk about postpartum psychosis. We'll touch on bipolar disorder. There probably is no time of life that's so exquisitely vulnerable to relapse and serious mood episodes as the postpartum in the lifetime of a woman with bipolar disorder. And we'll also talk about anxiety, which really is can be its own problem postpartum, but also concurrent with mood problems. So postpartum depression has been called the most common obstetrical complication. So it's estimated 10 to 15% of women will experience postpartum depression after delivery. There's even a higher risk in individuals who have histories of depression. And it's really, the technical definition is a major depressive episode that occurs postpartum and very often presents the same way, although the symptoms can often be more challenging to differentiate in the postpartum due to other issues like fatigue, sleep changes. Anxiety is often very prominent. So we know that anxiety is often comorbid with major depressive disorder to start with, but it's even more so in the postpartum. So if there's anything that really differentiates the postpartum, it's this, really heightened anxiety that we see a lot of individuals have. Not everyone has it, but when they do, it can be like absolutely torture for a new parent. And there is impairment in functioning, and we want to make sure that when we're assessing functioning, we're really doing that in the context at which a new parent would present. So that doesn't mean like doing everything that she would do before she had a baby, but basically being able to function in the role. So we know beyond a doubt that a maternal depression or a parental depression has a profound impact on child development, and postpartum depression or parental depression really, not only in the postpartum, but really throughout childhood impacts child development in almost every imaginable way. We're also gaining more and more appreciation that untreated mental health disorders like depression, anxiety during pregnancy really carry a long-term risk. So the in utero exposure to a patient being unwell from a psychiatric perspective may have lifelong consequences for that child, and actually could even have transgenerational effects beyond that. So could affect the grandchild, really. So and I think that that's what draws a lot of people to this field, is that treating the mother during pregnancy or postpartum really has a profound impact on the entire family. So postpartum OCD is very common and also can co-occur in part or in full with major depression or postpartum depression. So one of the major features of this are obsessions. So like textbook obsessions, like intrusive, distressing, recurrent thoughts that someone can't stop having even though they don't make sense. They very often take shape around the baby's health, for example. So a mom can't stop checking on the baby to the point where she's not getting any sleep or can't have like a loving, competent other adult like help with the baby's care. Sometimes these take shape around harming the baby. So a woman might have distressing, intrusive thoughts that she might hurt the baby, or that visions that something terrible is happening to the baby or might happen to the baby. For example, a woman might be afraid to cook because she's afraid of holding a knife, because if she's holding a knife, she could accidentally stab the baby, or she's afraid that if she's giving the baby a bath, that she could drown the baby. So the important thing about these obsessions is they are obsessions, like textbook obsessions, like recurrent, intrusive, distressing thoughts that don't make sense to the patient, do not fit with her thinking, they're ego dystonic. So she is very distressed by these thoughts, and patients often will not share these thoughts because they're so alarmed by them, they're so ashamed that they're having them. Sometimes people think that they made a mistake by becoming a mother, because how could they be such a terrible mother to have these thoughts? So it's really important, I think, that we actively screen for these because patients may not otherwise tell us. They also are often afraid that they're going crazy, that they're psychotic. And so that's a really important thing for us to be able to sort out, not only in perinatal mental health, but really on the front lines and in OB, emergency rooms. Like, it's really important from a multidisciplinary perspective that people are aware of postpartum OCD and postpartum psychosis, which we'll talk about later on in more detail. But the differentiation is often insight. So if someone is having postpartum OCD and these obsessions, she knows they don't fit into her regular thoughts. She's very bothered by them. They're very disturbing. Whereas with postpartum psychosis, which we'll talk about in a bit, it's very dangerous because it's in a delusional framework that a woman might be having thoughts of harming the baby. So she doesn't know she's having crazy thoughts. So it's, psychosis, as typical psychosis, that there is generally very poor insight. So with postpartum psychosis, there's a very high risk for harm to there's a high risk of suicide, infanticide, risk to other children in the home. It is a situation where almost every situation we can think of, we would recommend acute evaluation in a hospital setting and hospitalization for safety. Postpartum OCD does not carry increased risk of harm to the baby. And it is not a situation where patients generally need inpatient care. There might be cases that are so severe that someone might be hospitalized, but it's not the type of situation where it's like kind of the rule like it is with postpartum psychosis. One of the topics that is so important to talk about is breastfeeding. And we will talk about breastfeeding in the context of use of medication, but I will say that breastfeeding is by far the topic that I've seen more tears shed about in my office than any other topic. Nothing else comes close. And that's because there's been increasing pressure on women to breastfeed. So women hear breastfeed, breastfeed, breastfeed. They, breastfeeding education, breastfeed exclusively. And there are very clear public health initiatives to encourage breastfeeding and exclusive breastfeeding. So the public health guidelines encourage exclusive breastfeeding from the breast, not introducing bottles, not introducing formula, not introducing pacifiers, but exclusive breastfeeding from the breast. So that doesn't work for a lot of people. So first of all, breastfeeding can be very challenging and difficult to establish, which is why we have this whole healthcare category of lactation consultants, because it's often very difficult and women often need help, even when there isn't a psychiatric component. But there probably is a very complex bidirectional relationship between stress, psychiatric illness, and breastfeeding difficulty, where it's more difficult for some women to breastfeed. And if people are told over and over that breastfeeding is best and, and mothers want to be the best mothers they can possibly be. If it's not working out, people often feel like they're failing at motherhood right off the bat. So this is a very delicate life transition where individuals are establishing themselves as new mothers. And for those of you who have children, like it's, you know, and for those of you who don't have children, I actually just want to emphasize newborn babies need to eat every 1 or 2 hours, maybe every 3 hours if you're lucky. It takes a while to feed them. They don't just like eat, go back to bed. Like they're up for a while. And so it's an around the clock job. It's like being on call in an ICU every single night with no breaks. So if someone is exclusively breastfeeding from the breast, she is not getting any consecutive sleep. And when you think about the disorders that we treat, sleep deprivation can really worsen the course of a lot of illness, and regular consecutive sleep at night can make all the difference for some women in terms of staying well versus getting very ill, and can help women more rapidly recover. So I would say, you know, so in a perfect world, everyone would breastfeed and it would be great and there would, you know, it'd be easy. But it's just, that's not the world that we live in. But what we have now is we have these public health initiatives that are, and I don't know what your hospitals are like, but almost every teaching hospital in Boston has this baby-friendly designation. And I'm probably going to upset someone by saying this, but I think that baby-friendly, that term baby-friendly is like evil genius, because this baby-friendly designation means you don't have a nursery where the baby can go. You pretend formula hasn't been invented, and you really encourage moms to breastfeed at the detriment of everything else. And so again, if breastfeeding is working for someone, that's great. I'm not arguing at all against the nutritional benefits of breastfeeding, but I think for women who have serious psychiatric illnesses, it's not the most important thing. And so what we talk about, what we want to do when we have the opportunity is meet with patients, and if they have a partner, invite the partner to join for a pre-postpartum consultation. So during pregnancy, bring the partner in. If there's no partner, another family member, trusted friend, to talk about this topic, because very often women are literally driven to tears on this topic because they feel so badly when it doesn't work out. And very often when they're not well, they need the consecutive sleep and they need some bottles introduced. You know, sometimes that can be pumped breast milk in the bottle, can be formula. We need to give moms the formula, the message that their mental health is more important than how the baby is fed. And if people don't get that message from us, they're often not getting it elsewhere, because they often feel extremely, extremely judged. And there's no shortage of places to judge mothers. The social media has probably made it much, much, much worse. So, you know, women really need to hear that they can be a fantastic mother and not breastfeed. And it might, you know, sound obvious, but it's not for individuals who are in that situation, who are really struggling. So, you know, we have to make sure that that new women know, that new parents know that this doesn't define the type of parent that they're going to be. So in terms of postpartum depression, so who's at risk? So first of all, in terms of postpartum depression, it's almost like a myth that there's this one thing that's postpartum depression and that it's clearly differentiated from major depressive disorder. So for postpartum depression, there probably is just as much heterogeneity as there is for major depressive disorder, which we know for which there is a lot of heterogeneity. So for some women, they may have no histories of psychiatric illness and then suddenly have an onset of a depressive episode in the postpartum. And that may be different than women who've had recurrent depression and experience another episode in the postpartum, versus women who've maybe had chronic depression and have worsening in the postpartum. It's important to know that the natural course of depression during a pregnancy is to worsen greatly and rapidly in the acute postpartum. So we really want to take it as an opportunity to treat women during pregnancy to wellness before they deliver. So there's no single cause that we know of for postpartum depression. So there's not just this one hormonal cause. There's no hormonal abnormality that is really implicated and unites cases of postpartum depression. Now, my clinical sense is that there probably is a subcategory of postpartum depression that probably is driven by the hormonal changes that occur postpartum for some women, but absolutely don't know that we can apply that across the board. So there are major risk factors, and really history is a major risk factor. If someone's had a history of major depressive disorder or another mood disorder, those are highly recurrent. Having bipolar disorder is a major risk factor for serious illness in the postpartum, and postpartum psychosis is highly recurrent. And again, we will get to that a little more. There are actually so many risk factors, though, for postpartum depression that a list like this is often not helpful because so many women are at risk. And so it's hard to identify women who are well during pregnancy who's going to be at risk of postpartum depression other than those major risk factors, because again, there are so many different risk factors. So screening for postpartum depression has been a very hot topic, and a lot of hospitals have universal screening for postpartum depression. And it's important because it's often a misdiagnosis. So it's often missed, it's often confused with normal postpartum blues. And it's an opportunity because women have more contacts during pregnancy and the postpartum with healthcare providers than they might typically have like any other time of their adult life if they're otherwise in good health. And so there are different ways to screen. The Edinburgh Postnatal Depression Scale is probably the most frequently used, although the PHQ-9 is often used. But the Edinburgh Postnatal Depression Scale is free for clinical use. It's a self-rated 10-item tool that's easy and quick to fill out. And it's validated in many languages. So it's often the one that we see used. So screening is recommended in adults in general for screening for depression, and it's recommended during pregnancy and postpartum. And it's not like it's so easy to do, like making big system changes like implementing screening. I'm not saying it's easy, but it is the easy part compared to what has to come next. So screening by itself, not very helpful. So it might help like women put a label that they might have postpartum depression, but if we're going to screen, it has to be followed by evaluation. So the screen is not diagnostic, not helpful in and of itself. We want to make sure that women who do, score above a certain threshold are referred for evaluations in a timely manner, which is not so easy, and that they're referred to appropriate care and that they engage in that care and get well. And so these are all daunting tasks where we have shortages of healthcare providers, we have shortages of healthcare providers who feel comfortable treating perinatal psychiatric disorders. And, it's a time where, the healthcare system is hard enough to navigate if you have an MD or a PhD. And so for many patients, it's just an impossible task when they're depressed and they have a newborn. So, if one of my colleagues has said that he was going to make any major difference for the healthcare of women with postpartum depression, it would be to have more healthcare navigators in place. And so one of the I'll tell you about one resource, but Postpartum Support International is one resource that I can't say enough about, where there are resources for patients and healthcare providers, but for patients, they can go to the site and they can find local providers in their area. Now, in terms of treatment, for moderate to severe depression, antidepressants are absolutely first line. We always, there's often a lot of concern, especially if a woman is breastfeeding, similar to concern if a woman is pregnant. But if we're going to use medication, we want to make sure that we treat to remission. So very often what we see is patients are undertreated if they're pregnant or breastfeeding. And so we want to make sure that they're treated to remission. And very often women are anxious about taking medicines. Healthcare providers are anxious about prescribing it. So we just want to make sure that it's really clear that that's the outcome we're going for. It is a time to get consultation if healthcare providers are not comfortable treating women who are breastfeeding, and I'll tell you more about that too. We want to maximize all the non-medication alternatives, with psychotherapy being the most important. There are many evidence-based types of therapy that can be delivered in group and individual settings. And so this is, really well studied. I can't think of any situation where we wouldn't be recommending some form of psychotherapy to a patient. And one thing that is really, really helpful to many patients with perinatal psychiatric disorders is a group therapy. And so sometimes people can find that in their local areas. Postpartum Support International offers those online in a variety of sort of different categories during pregnancy, postpartum, anxiety, bipolar disorder, depression, something to fit almost everyone's needs. So, different, diverse groups that can really tailor to all aspects. And there's something special, I think, about a group therapy for postpartum depression or postpartum mood or anxiety disorders, because most women feel very alone and very ashamed, and they may feel like they're the only one going through this. And so it's important to be able to connect with other women that may be going through it so that they can feel less alone in the process. So this is the resource through Postpartum Support International. There's no cost. Patients can participate at no cost. There's a lot of different options in terms of scheduling and groups. And so I encourage you to check it out, because I refer like pretty much every single patient around pregnancy and postpartum for these groups. The other thing about Postpartum Support International is that they offer free consultations for healthcare prescribers. So if you prescribe medication and you want a perinatal psychiatrist to give you a consultation around that care, you can contact Postpartum Support International, and you can be at no cost. I think it's a great service. I'm totally biased. I volunteer for this service, but I think it's amazing. They also have a lot of trainings, resources, and educational materials for patients and their families. So in terms of antidepressants, there are enough studies that we know that antidepressants work for postpartum depression, similar as non-postpartum depression. There haven't been that many randomized controlled trials, I think mostly because of ethical considerations of randomization to placebo. So, but for all intensive purposes, antidepressants are considered first line for postpartum depression, as they would be for major depression. So antidepressants as a class are considered compatible during breastfeeding. There are two ways that we get information or see published literature on this topic. One is garbage, and that is case reports of N=1 or N=2 babies, were exposed to this medication during breastfeeding, and this thing happened, and there was an adverse event, and so it scares healthcare providers for like 2 decades to follow. For example, there was a case report of infant sleep trouble while the mother was using citalopram while the baby was just a newborn little baby. And newborn babies, as we were talking about before, do not really have any consolidated mature patterns of sleep. So sleep difficulty was reported in the beginning, and then months later, when the mom had come off the citalopram and the baby was like months and months older, the baby was sleeping better. So that is not a helpful case report, but it's still in the literature and it's still cited. The way we have good data is that mom-baby pairs have been in these rigorous studies that quantify the amount of a particular medication that may get into breast milk or infant blood levels. And for antidepressants, we have more data for antidepressants as a class than we have for basically any other category of medicine across all other categories of medications. So we have the most with the SSRI antidepressants. Sertraline and paroxetine have the most mom-baby pairs. Antidepressants in general are considered compatible with breastfeeding. So if a mom needs to be on an antidepressant, this would not be a reason to withhold care. So just, some caveats of how I think about individual antidepressants. Probably the most important thing is, what has a woman responded to? If you have someone who's had recurrent depression and she's had many medication trials in the past, then we want to go with something that works for that individual woman, even if it's not sertraline. So most people love sertraline in the context of breastfeeding because it has the most mom-baby pairs. It's generally well tolerated. And if someone's never been on an antidepressant before, it is totally reasonable to start with sertraline. But if someone has had, many antidepressant trials before, has not responded to sertraline, we want someone to get better and get better fast. And so we want to go with whatever's worked best for that patient. The other thing we never do is, if someone's doing well on something they've been on during pregnancy, we don't switch them postpartum, because the medicines just are not interchangeable. So we wouldn't swap out one for another in the postpartum when someone is so vulnerable to relapse. So with fluoxetine, which is Prozac, has a longer half-life than some other medications. and is more likely to be detectable in infant blood. Now, we never check that clinically. This is just from research studies. So, we don't check blood levels for babies, but it's, I think, sometimes misunderstood that because it's been detectable that women shouldn't use it when they're breastfeeding, and that's just not correct. So it's compatible in breastfeeding. If someone's on fluoxetine during pregnancy and doing well, we would never in a million years switch them to something else in the postpartum for breastfeeding. So we would just continue that medicine. And exposure is generally greater in pregnancy than in breastfeeding. So sertraline, again, is a great first choice. So are citalopram, escitalopram. Paroxetine, I think, is just not a first-line antidepressant anymore because of tolerability, but it's reasonable in breastfeeding. Bupropion potentially plays a special role in individuals who want to quit smoking or abstain from relapsing to smoking. So that might be something to really keep in mind. It's not as helpful with postpartum anxiety when that's part of the picture. SNRIs are considered compatible, tricyclics. We have no data for some of the newer antidepressants, but again, if someone has been really had a really treatment-resistant course of illness, we would still consider the class compatible. So we recently had 2 neurosteroids approved for the treatment of postpartum depression, which I think the most groundbreaking and exciting part of it is the FDA really recognizing postpartum depression as an indication for drug approval. However, it gets confusing because now the public and healthcare providers are hearing more about postpartum depression, but they're not often hearing the whole story about the evidence-based psychotherapies or other treatment options. But the first approved treatment was brexanolone, which is an IV-delivered treatment that's delivered over the course of 4 days in the hospital. I should say that Mass General was a research site for this, and zuranolone. Although we didn't enroll a lot of patients, we were a research site. Brexanolone has not really gained a lot of clinical traction because patients need to be in the hospital and it's very expensive, but it's delivered IV, appears to work very rapidly. And so at this point, I think we don't know exactly, who are the best patients for it. I have referred patients for it. It's very hard to get geographic, like even in Boston. I don't think we can get this treatment in Boston. I think the closest place to Boston is Providence, Rhode Island, to get this treatment. So this is brexanolone, and then zuranolone is the oral neurosteroid that was more recently approved. So last quarter of 2023, we were also a research site for this. I think that there's going to be more and more excitement about neurosteroids as a class. There are a number of companies that are developing them for multiple indications in psychiatry. So postpartum depression was just the first, I think. So zuranolone was looked at not only for postpartum depression, but also for major depressive disorder in men and women, and is not approved for that indication as of now. It is approved for postpartum depression, and it was looked at in studies as a monotherapy and for patients who were on antidepressants but still had postpartum depression, so onset of depression in the 3rd trimester or within 1 month after delivery. It's a 2-week course of an oral treatment, and they followed patients out to day 45. So a 2-week course and followed out to 45, generally showing benefit over placebo, with the biggest adverse effects being sedation. So you can now prescribe zuranolone for patients, and we have very limited clinical experience with this. So, it's brand new on the market. It's available at some pharmacies, but not all. So it's mostly available at specialty pharmacies. And I hear that some insurances are covering it, but we've had really limited clinical experience with it outside of clinical trials at this time. But it'll be interesting to see where it fits in the algorithm. But I think one of the important messages too is, it is exciting that we have this neurosteroid now approved for postpartum depression, but it's also important, as we educate our colleagues across fields, that we also have other treatments. So if, this isn't, the one for the patient, that we want to keep in mind that the standard treatments for postpartum depression are also available. So, and those include, psychotherapy. For patients with very severe depression, ECT is often not thought of enough, can be just a life-saving treatment. And then patients often seek out on their own complementary and alternative medicine treatments. And what I would just say is, that's a topic in and of itself, because I think we should hold every integrative treatment to the same standard as we would hold a prescription medication. We want the same evidence of efficacy and safety for everything. And so that would include like nutraceuticals or like whatever else patients might be taking. And I will say that you can let me know what you're seeing, but we're seeing in Massachusetts a lot of patients taking cannabis for different purposes. So we have medical and legal recreational legalization of cannabis, and patients often try and avoid using prescription medication and instead use cannabis without any evidence for safety and efficacy for the treatment of any of these disorders which we're treating. But what I think is really remarkable is that I think it's the stigma that so many patients often want to seek other treatments besides some of the evidence-based treatments that we have to offer. Now, there's such a risk of postpartum depression and such a rate of recurrence that there's some work to prevent it as well. And we want to start talking with women at risk during the pregnancy about how to, really engage in really careful monitoring across pregnancy and postpartum, and also what treatments might be on deck. So there are national recommendations to prevent postpartum depression, which are easier said than done. So it's important that we prevent it whenever we can. But if you think back on that long list of risk factors for postpartum depression, there are so many that if we were going to target all pregnant women in this country, there would be like too many to really offer the recommended treatments, which are evidence-based psychotherapies. So we do want to make sure that we're recognizing patients who are at risk and provide them with psychoeducation and resources as much as available. But it's a daunting task. It's easier said than done to identify and provide treatment to everyone who might be at risk. So in terms of prevention, the things that are most evidence-based are interpersonal psychotherapy, cognitive behavioral therapy. These can be group or individual. And as you can imagine, these are not available to every individual. And some patients also won't engage as well. There also have been some studies looking at medication, so starting immediately in the postpartum for women who've had postpartum depression before. And it does seem that starting an antidepressant in the acute postpartum for women who've had postpartum depression before but have stayed well across pregnancy may be a very viable alternative. So the clinical situation is that a woman may have had postpartum depression before. She's not on medicine and she's well across pregnancy. Because if she's not well, then we want treatment to start sooner, not later. But for those patients that are at high risk, we want to, at the very least, set up very close monitoring and a plan to start treatment early if with the onset of a depressive episode. But some women may opt to start an antidepressant right after delivery, and so that's like how real-time how this plays out in the clinic is what we offer patients is, if someone responded to sertraline, like, do you want to start sertraline right after you deliver, or do you want to wait and see what happens? And what is really like not on the menu of reasonable options is to have someone wait until they're really unwell. So we really want to enforce to patients that they can do whatever really like fits them, because these are really collaborative decisions. But what we really want to make sure is that we don't wait until someone's really, really ill before they engage in treatment. Now with bipolar disorder, so across the lifespan of a woman who has bipolar disorder, the postpartum is probably the most exquisitely risky time for serious illness. There's an increased risk with stopping a mood stabilizer really at any time, pregnant or not pregnant. But if for women who do stop mood stabilizers for pregnancy, there's a high rate of relapse during the pregnancy, and the rate of relapse is even higher in the postpartum. And postpartum psychosis is a major serious emergency illness. And also women with bipolar 1 disorder are probably at the highest risk of postpartum psychosis. That is the disorder that's most commonly associated with postpartum psychosis. So it's not necessarily clear that major depressive episodes are more common in the postpartum than other times of life, but it is clear that serious illness necessitating hospitalization is more common in the acute postpartum than other times of life. And that really represents bipolar mood episodes and postpartum psychosis, which may be part of bipolar disorder or might be distinct. So postpartum psychosis is considered a rare disorder, but it's not really that rare when you think about how many births there are in the US every year. So 1 or 2 out of 1,000 pregnancies ends up being a lot of possible cases of postpartum psychosis annually just in the US alone. There's usually an onset pretty rapidly after childbirth, although sometimes it's later. We want to suspect bipolar disorder. Sometimes women have no history of having had a psychiatric illness before, and so the question is that if someone has postpartum psychosis in the absence of a history of a psychiatric disorder, really carefully taken history, we often don't know what that is, because sometimes women seem to have a circumscribed psychotic illness in the postpartum, but we want to treat women, at least initially, as if they have bipolar 1 disorder. So there's often mania associated with the psychosis, and it is an emergent condition. There is a high risk of terrible, horrific outcomes, with suicide and infanticide being among those. So I want to refer you for more information on this topic to mghp3.org, which is the Mass General Postpartum Psychosis Project. There's a lot of information for healthcare providers here and for patients and their families. We are offering free consultation for healthcare prescribers who are treating postpartum psychosis. So if you have a case of postpartum psychosis, or a colleague is treating someone with postpartum psychosis and wants a consultation at no cost, you can call our program and you can get that. But there's more information here. But part of the reason we're doing this study is because we want to understand more about what postpartum psychosis is and how to identify women who actually have the onset of a bipolar disorder and will need longer term care versus those who might have a more circumscribed illness and may not need lifelong treatment with mood stabilizers. So women who've, may seem obvious, but those who do have bipolar 1 disorder, histories of psychosis, past hospitalizations are the ones at higher risk. So acute treatment, hospitalization is generally the rule. We want to, treatment involves medication. Usually lithium is the mainstay of treatment with an antipsychotic, usually an atypical, also mood stabilizing, but a lot of patients don't get well with just antipsychotic medications. So lithium often makes all the difference. So treatment after discharge, it can often be, really difficult to ascertain how patients need treatment, because if it is a bipolar disorder, they may need indefinite treatment. And whenever we're taking someone off medication, we need to really worry about recurrence. But generally, we say that we want to treat after someone's well for 6 to 12 months. Make sure that there are supports in place, because we're sending, a new mom with a serious illness home where there's a new baby. We want to make sure that the whole, that woman's frontline is really educated about the risks, because families often have no idea what's going on, really. And so we want to make sure that everybody's safe at home. So some of the main points with postpartum psychosis versus bipolar disorder is, with bipolar disorder, individuals are at risk whenever they're off of medication. So the risk of relapse is high across pregnancy and postpartum and other times. With postpartum psychosis, if someone really only has a circumscribed postpartum psychotic episode, the risk may not be apparent. Like if someone stops medication, they're not pregnant, not postpartum, then they conceive another pregnancy, but they are at exquisitely high risk for subsequent postpartum periods. So it's recommended that women who've had postpartum psychosis, been treated, gotten better, and then have had another pregnancy and are still off medication, that they restart medication at the very latest, right after delivery. So we would restart medication in our program in the 3rd trimester at the latest. If someone refuses, okay, but we would really encourage them to start right after delivery, with lithium being the medication that's been most established for prevention of postpartum psychosis. We also want to talk about sleep and support. So very often, especially in the US, women often feel like they have to do everything alone and do it well. So we want women to really feel comfortable asking for help. We want to talk about sleep plans because, if there's a partner, then we want to make sure that they're both educated about the importance of sleep. Medical couples really get this. So if you talk about signing out the baby for a few hours every night so that moms can get some consecutive sleep at night, that's really important. It's not enough, in my opinion, to talk to women alone about this, that you really want to encourage them to bring a partner, if there's a partner, or another family member to talk about this, to brainstorm how to get some sleep. If individuals have resources and can get a night nurse or a night nanny, that's fantastic, but it's really out of reach financially for most people. So regarding mood stabilizers and breastfeeding, lithium is the most complicated medication for breastfeeding because there have been enough adverse effects for the use of lithium in breastfeeding that it's been contraindicated at one point by the American Academy of Pediatricians. We generally don't recommend it for use during breastfeeding. Now, we do recommend lithium, but we recommend that women who need lithium or have done well on lithium, that they don't breastfeed. But there are also guidelines for using lithium and breastfeeding and what monitoring should be done, like checking, if the baby's healthy and has a collaborative pediatrician, you can follow some medical parameters and labs to try and do this safely. Lamotrigine and atypicals are considered considered reasonable, although we know more about some of the atypicals than others in the context of breastfeeding. So to get close to wrapping up, just talking about some of the barriers to care and also tools, it's an opportunity, but also a challenge to really have a multidisciplinary approach to this. And I had a colleague once say that we want to make sure that any door a woman knocks on is the right door. So we want to make sure, many women who could benefit by seeing a perinatal psychiatrist may never meet one. She may never go to a psychiatrist or have that kind of access, but we want to make sure that our colleagues in OB and primary care are supported and educated in this area. And also adult psychiatrists often don't feel like they get enough training in this area. Telehealth has been a real game changer. We are able to see patients more frequently. It's not so easy to get to appointments with a new baby, like a 8-pound baby. To get out of the house with an 8-pound baby often requires 50 pounds of stuff. It's really hard for people to get to appointments. So telehealth really allows us to help people engage in more frequent appointments when they need them. But I think it doesn't take the place of in-person care. And then stigma is also a major factor. So I think at this point, we have some time for some questions. I want to leave you with our website for more information if you're interested in our virtual rounds. There's a lot of educational materials also on our site. And I just want to mention too that we have a blog that comes out weekly with new, basically summarizing new research on women's mental health. So you can sign up to have that delivered by email, or you can just check it out on our website. So thank you very much, and I think we have some time for some questions.
Thank you so much for that comprehensive presentation, Dr. Freeman. I'm happy to read questions if people want to throw them into the chat, or if you want to unmute yourself and ask directly, that would be great. I know I have many questions on my mind, but want to allow the opportunity for everyone else in the audience to ask theirs.
I've got a question. Hi, Dr. Freeman. Thank you for that presentation. I feel like when we're talking about postpartum psychosis, we're often talking about either like an isolated postpartum psychosis or in the setting of a bipolar disorder. And I'm curious, if there's any kind of data about maybe just postpartum depression with psychotic features. So maybe you're lacking kind of the manic components, but you just have maybe some delusions, or what that would look like, and if you've seen that before.
Yeah, so that's an awesome question. I appreciate it very much. Again, it underscores why we're doing the MGH postpartum psychosis project, because that does occur too. And at this time, we don't have data to differentiate really the different presentations and what they mean longer term in terms of diagnosis and treatment. So it's basically a registry for women with postpartum psychosis where we do really careful interviews with phenotyping, like get really careful histories. We're getting DNA when patients are willing to give samples. We've done some neuroimaging as part of that study, but you're spot on that we don't have a lot of answers to that, and that is how some women present. If you have any patients that have had a case of postpartum psychosis within the past 10 years, we would be so grateful if you would refer them to the study, because that's exactly the type of question that we want better answers for our patients.
Quite a few questions in the chat. Dr. Hensley, looks like your hand is raised as well. Did you want to ask yours?
Sure, thanks very much. Great presentation. I really appreciate the resources too. So I just had a question about the postpartum OCD, which I've seen a fair amount actually on inpatient units where, they come to the emergency room, they're having intrusive thoughts about harming the baby, and everyone kind of freaks out and admits them, usually because the woman wants to be there. And they're very anxious. And so, we treat them. And so in that context, it's been very short-term treatment, but I'm just kind of wondering, and I realize this probably isn't, your specific area of expertise, but would you say that the treatment is similar for non-postpartum OCD? I mean, many of these patients have, maybe a history or a family history of that. So is it still recommended that you run doses up pretty high? Are there studies on exposure and response prevention? And do you have any concern about breastfeeding for these women who might be on higher than usual doses of SSRIs? Thanks very much.
So the treatment is similar to OCD that would occur at other times. I think that one of the most difficult illnesses that we treat is postpartum OCD, and women who've had it before are at risk, family histories. But it's hard to even put into words what an exquisite form of torture postpartum OCD can be, and how unrelenting it can be, and how difficult it is sometimes to break. And so we do treat with SSRIs first line. We usually treat with benzodiazepines unless there's an absolute contraindication, because we need people to have some relief as soon as possible. We're very curious to know if those neurosteroids that were recently approved are going to work for postpartum OCD. We don't know yet. Psychotherapy is really important, but we often see people who are too ill to really take advantage of cognitive behavioral therapy when they first present, but it's always part of the follow-up plan. And then I think also, for some women who've not presented for care before, just knowing more about it can be a huge relief that they're not alone, because they often feel terribly alone in the situation.
Dr. Tohen, did you want to go ahead and ask a question, and then I can read those that are in the chat?
You decide, Dr. Rose.
Please go ahead.
Thank you. Great presentation, Dr. Freeman, Marlene. Learned a lot. Following the question of Dr. Rose, Rachel Rose, in terms of bipolar presentation or psychosis without mood symptoms, there's been any studies actually looking at family history compared to, say, a psychosis not on a postpartum? If there's a larger, prevalence of family history of bipolar in those patients who have postpartum with no mood features. And then I have then a second question is, what about differences across demographic groups, having to do not only with biology, but also culture? For instance, a comparison of population in Massachusetts compared to a population in New Mexico with a large Hispanic and Native American communities. Dr. Freeman.
That's a great question. No, I think the truth is we don't know the answers to most of those questions. And because it's considered, relatively rare disorder, there hasn't been a lot of research. And so, I think that we have more research for women with bipolar disorder in general, but there are a lot of unanswered questions. But one of the things that, you mentioned cultural differences. One of the things, I don't know if there would be any cultural differences in the expression of an illness. But what I have appreciated is there is a very high tolerance for some families to basically tolerate a lot of, for lack of a better word, craziness at home before they're willing to seek mental health care. So a lot of times families have no idea what's going on. I have had not one, but two patients who've sought exorcism in their homes before they've sought mental health care. So there often is a religious component to postpartum psychosis, which I think sometimes, you know, it's not at all unusual for patients to present to clergy before they present to mental health care providers, particularly if, you know, the family doesn't, you know, have much of a background or education around psychiatric illnesses. So it's not at all uncommon, but we're just desperate for more information to help inform, like really identifying who's at higher risk and then how to best treat people.
Maybe we should consider a collaborative effort and compare the Massachusetts with New Mexico.
We would love that, actually. We would absolutely love that.
You got that, Dr. Rose?
I hear that, yes. Okay, so a few more questions that are in the chat. Thank you. Can you speak briefly to setting of care leading up to delivery for women with severe mental illness? For example, inpatient labor and delivery floor for a psychiatric unit. Are there any guidelines or recommendations regarding treatment setting?
I'm not sure I understand the question exactly.
Would you like to, you know, I'm going to butcher this last name. So Dr. Nikogozian, would you like to elaborate?
Yeah, hi, sorry. Thank you for the wonderful talk. I really enjoyed your lecture. Yeah, the question kind of comes more to with someone who has either decompensated bipolar or schizophrenia, and they're coming pretty close to delivery, if not within days. Is there any recommendations and guidelines? When are they more appropriate to go perhaps in an inpatient like labor and delivery floor versus waiting until they're about to start delivery on the inpatient psych unit?
That's a really interesting question. I've never been asked that before. I mean, we've certainly had patients who were inpatient psychiatrically and then transferred for delivery if they've been really acutely ill. I think preventatively, you know, we don't, you know, what we try and do is just provide the most information to the patient and the family, and you know, and think ahead, you know, with like where is she going to deliver. One of the important things I think is to make sure to address the breastfeeding issue and sleep, and start talking as early as possible about supports at home and who's going to help with the baby. And so, and then the other thing would be the very important role of the consult liaison team if someone is not well around labor and delivery.
Okay, can we sneak in one more question that's in the chat, Dr. Freeman? You have time for that? Okay. Forgive me if I missed this, but is there any evidence correlating type of birth or birth complications with postpartum psych issues such as precipitous birth, pain control, etc.?
So there is an increased risk of postpartum depression with obstetrical complications, but obstetrical complications are incredibly common. So it's probably like a very complex and bidirectional that women who have psychiatric illnesses are probably at higher risk of obstetrical complications, and vice versa. So, but you know, I think we're, as a field in perinatal mental health, we're gaining also more appreciation for the traumatic experience of obstetrical and neonatal complications. And so I think that there's more and more work being done around that as well, because many women really feel traumatized by the experience they have. If they have, you know, there are very often, you know, catastrophic events that unfortunately occur in this context.
Great, thank you so much.
I hate to end on that note.
I appreciate everyone's engagement. Lots of fantastic questions and voiced gratitude in the chat for your time. We really appreciate you speaking with us today.
Well, hopefully we'll be in touch. And again, I really appreciate the invitation. Thank you.
Yeah, absolutely. We will be. Take care. Thank you, everyone.